Hey everybody, this week we're going to be talking about the kind of the basics of interpretation of EKGs. So this is kind of an important topic for respiratory therapists because in a lot of facilities you might be the one that's performing the EKG. So in therapeutics too, you're going to be learning about, the actual procedure. And in this course, we want to just kind of follow up on some of the information you learned in Chapter 5 about the structure of the heart. Add to that with some conversations about the electrophysiology of the heart and what actually these EKG readings are telling us. All right, so just a couple learning objectives that we want to cover here. And then when we're getting into what an EKG actually is, this is just really a very, very popular, commonly used diagnostic tool in the hospitals that we use because it's inexpensive, it's non-invasive, meaning that we don't have to actually, inject anything in the patient or take any samples from the patient. So it's fairly easy to obtain. Okay, so it's used a lot for any patient that we suspect are having anything like dysrhythmias or any heart condition. So it really can help us a lot with differential diagnosis because a lot of heart patients are going to come in presenting with the same symptoms that our respiratory patients are presenting with. We also use these as a screening tool in patients over the age of 40, usually before they have procedures or surgery. And it's important to remember that these don't predict heart attacks. So I can't have one, every week just to make sure I'm not going to end up having a heart attack in the next week or so. It can't also detect any structural defects. So there's a lot of structural issues with the heart. That, with valves and things like that can also create cardiac issues. And for those, you would need to have an echocardiogram performed, which is a little bit more intensive. Okay, so kind of some of the basic principles of the electrophysiology of the heart is that, there's an impulse conducting system, okay, that is built into the structures of the heart that provide like electrical stimulation to the heart muscles, which will cause those contractions to happen. So the cardiac cells are polarized with positive energy on the outside and negative on the inside. So when they're stimulated, the cardiac cells depolarize as sodium rushes into the cells. Okay, so that depolarization is what's going to cause those heart muscles to contract momentarily. Okay, then the heart cells are going to repolarize and reestablish that electrical imbalance across the submembrane and make it ready for the next contraction. Okay, so because these the energy inside the cells and outside the cells has everything to do with certain electrolytes. That is why electrolyte imbalances in like sodium, especially potassium or calcium, can cause dysrhythmias in patients. So that is one of the reasons why electrolytes are so important to heart function, because that is what's moving into and out of the cells to cause this depolarization and repolarization. All right. So the impulse conducting system has 3 different parts or types of cells. So there's the pacemaker cells. So this is usually the SA node, or the sinoarterial node is considered the pacemaker of the heart. It's at the top of the heart. There's also specialized rapid conducting tissues. So these are usually the Purkinje fibers that are going to kind of go on the outside of the ventricles, allowing for complete ventricle contraction. And then you have your atrial and ventricle muscle cells. So all of these cells have the ability to kind of what we would call spontaneous depolarization, meaning that they do it kind of automatically without impulses from the other systems. And that is what sometimes happens when you have certain types of dysrhythmias, is some of these impulses are happening without that conduction throughout the whole system, or kind of improperly or out of order. So that conducting or impulse conducting system is responsible for initiating the heartbeat, controlling your heart rate, and coordinating the contractions between the heart chambers. So it's really important for our blood pressure and our vascular function that the atria contract first, emptying into the ventricles and then allowing for that ventricle contraction. So if that doesn't happen, we miss out on a lot of our preload, making it difficult for us to maintain good cardiac output. So any type of defect to the system, as I mentioned, is going to potentially lead to inadequate cardiac output. And if we don't have good cardiac output, we're going to have decrease in that tissue perfusion. Okay. So looking at the heart structures again and looking at kind of the action potential and in relationship to the EKG tracing. I really like this imagery because it kind of shows you as this action potential moves throughout the heart, which wave or which part of the waveform we're creating. So if you see here up at the top, this SA node when it has its action potential, that is going to cause the atrial muscle contraction. Okay, so SA node is up here. This is going to be what causes the impulse to contract these two atrial muscles. Okay, and when that happens, you look down here, that is what's going to create what we call the P wave on the ECG tracing or EKG tracing. Okay. Next, the impulse is going to move to the AV node, the atrioventricular node. Okay, there is a pause at the AV node, and that pause is important, and what creates what we call the PR interval. That pause is important because what this does is it allows the atrial muscles to contract completely and empty completely into the ventricles, meaning that I've filled my ventricles up with all the blood that returned to the heart so that I have a good preload for that cardiac output. Okay, so there's a pause right here, and then the impulse is going to go down the Purkinje fibers. Okay, so it goes down the bundle branch, goes up these Purkinje fibers, and that is what's going to create the ventricle muscle contraction, which you see represented as this QRS complex. Okay, so if you're going to calculate the heart rate based on an ECG tracing, you're going to do that based on the number of ventricle contractions you see, because that's what creates your pulse. So the number of QRS complexes that you see. Okay, so your T wave then is just that repolarization phase where the energy potential kind of returns to that resting so that, the heart is ready for the next contraction. Okay, so to talk about this a little bit more in depth, we have that sinus node, that SA node, which is that specialized cardiac muscle that is connected to the atrial muscles, so it's going to control those atrial contractions, and this acts as a pacemaker of the heart, okay? So when the membrane potential here reaches like -40, you are going to have the leaking of the calcium and sodium channels in the cell membranes and causing that action potential, okay? So, and then after those calcium channels closed, you're going to have the potassium channels open and return that membrane to the normal potential, that resting -55. Okay, not so important that you understand necessarily what millivolts or things like that we need to reach in order to achieve repolarization and depolarization. I think that's really in-depth cardiac stuff. I just want you to understand that it's the movement of these sodium, calcium, and potassium ions through those cell membranes that's causing this depolarization and repolarization, because that just emphasizes the importance of these electrolytes in cardiac function. Okay. All right, so the normal rate of that SA node is going to be, somewhere between that 70 to 80 beats per minute. Okay. The AV node, if we bypass the SA node and the AV node is the only thing that's causing impulses in the heart, your heart rate is going to drop between, to like 40 to 60. So that's why a lot of times when you see these heart block patients, their heart rate is usually a lot slower. Okay, and then if you're just relying on those Purkinje fibers for impulses, your heart rate is going to be really low, 14 to 40. Okay. So that sinus node then becomes the pacemaker of the heart because it has that fastest discharge rate. Moving on to the AV node, this is, like I said, this is kind of the midpoint in this impulse conduction. We use the AV node to kind of delay that cardiac impulse. Most of the delay happens at that AV node so that you can have that complete emptying of the atria and allowing for that filling of the ventricles. Okay, so those AV bundles, it's important to understand that this should be one-way conduction. So those impulses are supposed to go only one way through the atria and the ventricles, because otherwise you're going to have the impulse going back and causing dysrhythmias of additional heartbeats, okay? Or additional contractions, I should say. That's a better way of saying it. Okay, so the conducting path between the atria and the ventricles is that AV node and those AV bundles, and it's divided into this left and right bundle. Okay, so this transmission time should be really, really quick. That's what causing that QRS complex to be very, very narrow. So if this transmission slows down, you get this widening of this QRS complex, which can signify issues with that cardiac tissue, or issues with electrolyte balances and, risk of cardiac problems for the patient. All right, so your Purkinje system, these Purkinje fibers, these are, again, the specialized conducting tissue. These fibers lead from kind of the AV node through that AV bundle into the ventricles. So your AV node here, this is the bundle of His. You have two branching of the two bundles, right and left, going to the bottom of the ventricle, you see. And then you see these Purkinje fibers going upward, back upward through the ventricle. That means that the impulse goes all the way to the bottom before traveling up, which is making the heart start the contraction at the bottom and move upward. Okay, so these Purkinje systems, very large fibers, and has very fast conduction then. Okay. All right, so you can have this ectopic pacemaker. So this is the portion of the heart with a more rapid discharge than the SA node. So the SA node up here is going to discharge as quickly as if you have these ectopic pacemakers where it's discharging down here. Okay, so it occurs when transmission between that SA node and the AV node is blocked. So in heart blocks, this is what happens. So instead of having the impulses coming from up here throughout the heart, it comes from down here. It's not going to be as fast of a rate, but the discharge or the impulses go quicker through the system when it comes from there. Okay, so the parasympathetic system is going to have some effects on your heart rate. So their parasympathetic nerves or nervous system or impulses are usually what happens when you stimulate that vagal nerve in your body. Or you have a release of acetylcholine. Okay, so acetylcholine, what it's going to do is kind of innervate the SA node and that junctional fibrils, which is going to cause hyperpolarization, okay? Because there's going to be that potassium is going to become very, very permeable in response to the acetylcholine, okay? So what then happens is you're going to have decreased transmission of those impulses, and your heart rate is going to slow or stop. Okay, and what sometimes they'll call this ventricle escape. Okay, so the sympathetic effects on our heart. So kind of should have learned these a little bit in pharmacology, because you should have talked about sympathetic and parasympathetic nerve impulses already. But those sympathetic effects on the heart, with the release of norepinephrine, that's going to cause an increase in that SA node discharge, which means that my heart rate is going to increase. So the rate increases, conduction of the impulse that increases. It also increases the force of those contractions of the atria and the ventricles. So just to recap again, normally that SA node is going to have the greatest degree of effect on the heart and paces the heart. The AV node serves as kind of a backup pacemaker if that SA node fails. And then after leaving the AV node, those impulses are going to travel through those bundles of His, those bundle branches, the right and left, and then back up the Purkinje fibers. Okay, so that's how that impulse conducting system works. Okay. So, as I mentioned before, in some healthcare organizations, the respiratory therapists are going to be the ones responsible for troubleshooting ECGs. As a result, you as a respiratory therapist should be really familiar with how to set up and perform such a test. Once the physician orders a 12-lead ECG and the equipment is gathered, which includes like your portable ECG unit, lead wires, electrodes. You're going to place the 12 leads subdivided into two groups on the patient. So this is a typo here. This should say 4 limb leads, not 6. So this is 4 limb leads. You have 4 limb leads and you have 6 pectoral leads, which really means that you're actually using 10 wires to do a 12-lead EKG. So limb leads are bipolar and able to monitor the heart's activity that is directed kind of up, down, left, and right. So typically your limb leads are going to be called things like 1, 2, 3, and then you have your AVR, your AVL, and your AVF. Okay, so the chest leads or the precordial leads are unipolar, meaning that they can only measure the cardiac activity moving anterior or posteriorly. Okay, so these are usually labeled as V1, 2, 3, 4, 5, and 6. Okay, so the ECG helps to diagnose certain types of conditions, like I said, the myocardial infarction, the cardiac ischemia, and it does this by looking at different directions of the electrical activity through the heart, okay? So it can narrow down, instead of just that there is an issue, it can narrow down what side of the heart that issue is occurring in. So you could have like a myocardial infarction that is anterior, okay, versus posterior, or left anterior, right anterior. So it helps the doctor when he's looking at the different leads understand what portion of the heart, because you remember the heart is this 3-dimensional object, which portion of the heart the issue is occurring on. Okay. So this figure kind of just shows the proper precordial lead placement. So you have your angle of Louis, which you feel kind of at the top of your rib cage. Okay. And then you're going to kind of look for, this ends up being 1, 2, 3, 4, 4th to 5th intercostal space. We're putting V1 and 2 right on the opposite side of the sternum. And then V3, 4, 5, and 6 kind of curve around the bottom. of the rib on the left side. Okay, like I said, Jim is going to go through that a lot more for you in your therapeutics class. Okay, so after you perform the procedure, you're going to get a EKG tracing on kind of grid paper. So there's these grid-like boxes there, and there's a horizontal axis, which defines time, and a vertical axis, which defines voltage. Okay, so one large box is equal to 0.2 seconds. Okay, and that's important when you're calculating out the rate. And one small box is going to be equal to 0.04 seconds. So there's 5 small boxes in every large box. Okay. So 1 millivolt of voltage is going to create an upward deflection of 10 boxes, okay, which should represent that depolarization of the ventricles. Okay, so this is just kind of an example of what that ECG paper should look like. Just is kind of blown up, and then you have all the little box segments. Okay, so your bipolar limb leads. So this is just showing the direction of the energy. So lead 1 is going from the direction of flow is from your right arm straight through to your left arm. Lead 2 is looking at the energy going from your right arm through to your left foot. And lead 3 is going from your left arm to your left foot. So it's looking at different angles of the heart. Okay. So your AVR is kind of your right arm as a reference point. So if you think about looking at this Evenhoff's triangle, this is just kind of showing you, again, the direction of the energy, flow of energy or voltage through the heart. So these are your unipolar limb leads, your AVR, your right reference, your AVL, moving through to your left arm as a reference, and then your AVF with your left leg as a reference. Okay, so your precordial leads then help with, understanding the direction of that energy. You've got your lead 1 here, and all of these lead wires that are going to factor into that. So these chest leads, known as V1 through 6, are very sensitive to that electrical potential change underneath those electrodes, and can help you kind of get a clear picture of those underlying cardiac issues. So this axis evaluation, what it does is it helps determine the general direction of the current flow through that ventricle polarization and detect any type of hypertrophy. So, normally that mean axis is anywhere from 0 to 90. If the right axis deviation is consistent with right ventricle hypertrophy, left axis deviation is consistent with left ventricle hypertrophy. So I do have a short YouTube video that I think does a good job of explaining this.
There's just so much I want to say about this. So the shampoo and conditioner, again called Hydrate with a number 8, because it provides.
Cardiac axis is the net direction of electrical activity during depolarization. In a healthy heart, the net movement is downward and slightly left. This axis is altered or deviated in certain conditions. For example, in left ventricular hypertrophy, the axis is skewed further left, while right ventricular hypertrophy results in a deviation to the right. Cardiac axis can be determined by examining the 6 limb leads, which look at the heart from different angles in a vertical plane. The QRS axis is the most important and also the easiest to be determined, as it represents ventricular depolarization. The QRS axis is considered normal when it is between -30 and +90 degrees. Left axis deviation is between minus 30 and minus 90 degrees. Right axis deviation goes between plus 90 and plus 180 degrees. The rest is known as northwest axis or extreme axis deviation. Remember that depolarization toward a lead produces a positive deflection. Depolarization away from a lead gives a negative deflection. Impulses moving at a 90-degree angle relative to a lead produce an isoelectric or equiphasic result with positive and negative deflections of similar amplitude. There are several methods to estimate the QRS axis. We will discuss two of them. The quadrant method. This method looks at the QRS complex in lead 1 and lead AVF. If the QRS complex is mostly positive in both leads, the axis is somewhere in between the two leads, which is in the normal range. If it's negative in lead 1 and positive in AVF, the axis runs away from lead 1, but toward AVF, and is thus in the lower right quadrant. The diagnosis is right axis deviation. A positive value in lead 1 and a negative value in lead AVF place the axis in the upper left quadrant, which interprets as possible left axis deviation. A more accurate method will be needed to further determine if it is borderline normal or left deviation. Negative values of the QRS complex in both leads are indicative of extreme axis deviation. The isoelectric lead method. This method consists of finding the isoelectric or equiphasic lead, the one with equal or nearly equal negative and positive deflections. The axis line is perpendicular to the direction of the isoelectric lead. Next, look at the lead that runs nearest to this line. If the QRS complex is positive in that lead, the axis points to roughly the same direction as the lead. If it is negative, the axis points to the opposite direction.
Right. So now let's get into the application of this to actual EKG rhythm strips. So the first thing that you want to do when you're looking at an EKG rhythm strip is identify both the atrial and ventricle rates. So those should be in a normal sinus rhythm the same thing. So in order to do this, I need to be looking for the P waves and the QRS complexes. My P waves are going to give me my atrial rate, my QRS complexes are going to give me my ventricle rate. Okay. Then I want to look at the relationship between those PR intervals because that's what's going to help me identify heart blocks. Okay. I can then evaluate the QRS complex to make sure that it's not widened. I can evaluate the T wave to make sure it's not inverted. That usually indicates a history of a myocardial infarction. I can evaluate the ST segment to look to see if it's elevated or elevate. What's the opposite of elevated? Elevated or like decreased. And that also is a huge indication that the patient is in the middle of an MI. So they're actively having a heart attack. And then I want to look at things like the RR intervals to evaluate the regularity of the rate. And you can finally identify the mean QRS axis. Okay, so when I'm looking at the atrial rates, or ventricle rates, I'm counting the boxes. So like if you think two large boxes, if I have a heart rate, if there's, two QRS complexes within two large boxes, or there's two large boxes between each QRS complex, I'm thinking my heart rate is going to be above 150. If there's about 4 boxes in between, then my heart rate is fairly normal. It should be around 75. If there's 6 large boxes, then my heart rate is low, which meaning that my heart rate would be around 50. Okay. So again, this is a nice picture just of like what's happening in that electrical activity and an ECG. So you're starting with that SA node. The impulse gets to the SA node, and then it's going to be transmitted, should be down to the AV node, and as it's getting transmitted, you're having that atrial contraction. Down here, it's hitting the AV node, going down the bundles, and then back up the Purkinje fibers to cause that ventricle contraction. Okay, ventricles contract, and then you have that repolarization to go back to that resting heart rate. So this is kind of your P wave, QRS wave, T wave. So that PR interval is that time from the start of that atrial contraction to the start of the ventricle contraction. So this is normally not supposed to be greater than 0.2 seconds. So one of those boxes, big boxes. So a longer PR interval indicates some type of a heart block. Usually a first degree is just a long elongation of a PR interval. Okay. Your ST segment is the time from the end of that ventricle depolarization to the start of the ventricle repolarization. So if it's elevated or depressed, that indicates myocardial ischemia, so blockage of blood flow to the heart muscle, which is considered an MI, or injury to the heart muscle. So this is what a standardized EKG looks like. So you have your P wave, your PR interval here, your PR segment. You have your QRS complex here, your ST segment, and then your QT interval. Okay. And then this map just shows, again, where, this is kind of hard to see with the purple, but where things are occurring. So here is that impulse, creating that P wave. This is your PR interval from the start of that impulse to the complete contraction. Here is that impulse going to the ventricles again, causing that QRS complex, that QRS contraction, causing the ventricle contraction, and then back at 6 where you're getting that T wave with the repolarization of the heart. So that QT interval usually has a normal value about 0.35 seconds. That's the kind of duration of the time between the Q wave and the end of the T wave, and it approximates that ventricle contraction. Usually we look at identifying the heart rate, so we can identify, the difference between the normal sinus rhythm, sinus tach, sinus bradycardia, by counting the time between each of these intervals. Okay. So for your ST segments, A here is representing a kind of a normal ST segment. So you have your the time between this is your QRS complex, your S and your T. The line is kind of flat along the baseline, okay? B shows an abnormal elevation, so this is that ST elevation, or sometimes referred to as a STEMI in the hospital. C shows that abnormal depression, which also can indicate cardiac injury and ischemia. So for normal sinus rhythm, what we're looking for is that it has that upright P wave, okay? That PR interval is going to be less than 0.2 seconds. You have normal, identical QRS complexes throughout the rhythm strip. That ST segment is flat, and your RR interval is regular. Okay, so if you're looking at a normal sinus rhythm here, this shows a normal P wave. My PR interval is less than one big box. So I have a normal PR interval with each of these complexes. I have a regular RR interval, meaning the difference between these two complexes is the same as the difference between these two complexes as these two complexes as these two complexes. Okay, so this is and I have a T wave. So this is a normal sinus rhythm. Okay, there's about 4 boxes between each of these QRS complexes. So my heart rate is somewhere around 75, which would be a normal heart rate. Okay, so for sinus tachycardia, this is anytime you have a normal sinus rhythm, but the heart rate is higher than 100 at rest, okay? So your QRS complexes still have to have a P wave in front of them. Typically, you find sinus tachycardia in patients that have acute illness. It can be caused by pain, anxiety, fear. If the patient's hypovolemic, their heart rate's going to increase to kind of compensate, to try to improve their blood pressure. Or if they're hypoxemic, they're going to try to increase their heart rate to improve that oxygen transportation. Can also be caused by certain medications, such as bronchodilators. Remember, that's going to stimulate our sympathetic nervous system, which is going to cause your heart rate to increase. And to fix it, we want to treat those underlying causes. So if it's caused by anxiety, treat the anxiety. If it's caused by the hypoxemia, treat the hypoxemia. Okay, so here in our picture, you're going to see a P wave again. A normal PR interval, so this PR interval is less than one of these big boxes, so our PR interval is the same between each of these complexes and less than one of the big boxes. We're followed by our QRS complex is followed by a T wave, okay, but you notice here that there's about 2.5 boxes between each of these QRS complexes. So my heart rate is probably somewhere around 100 and between 120 and 150. Okay, so I know that this is a fast heart rate due to even though it's regular, it's fast between these QRS complexes, but I still have all of the required impulses or the required tracings. So this is still sinus, normal. It's still a sinus rhythm, but it's just fast, so we call it sinus tachycardia. Okay, so sinus bradycardia is where your heart rate is less than 60, but again, I have all of those normal pieces in my EKG rhythm strip. So I'm going to have a normal P wave that precedes a QRS complex. That PR interval is also normal, less than 0.2 seconds. And this sinus bradycardia is usually only something that we get worried about when it causes clinical problems. So I'm not worried about sinus brady as long as my patient's blood pressure is normal and their mentation is normal. But if they're hypotensive or they're having any syncope, I would be concerned and would want to treat it. So atropine or epinephrine is usually what we use to treat sinus bradycardia. Okay, so again, here you see the P wave. Normal PR interval, less than one of the bigger boxes, followed by a QRS complex and a T wave, okay? But you notice that in between each of these QRS complexes, we have 1, 2, 3, 4, 5, 6.5 boxes. So my heart rate on this patient is somewhere like around 40 beats per minute, so. Okay. So you can have sinus arrhythmias too, and this is recognized by any irregular spacing between those QRS complexes. Okay, so that means that I don't have a regular QRS complex. This can happen because of, sometimes irregular. If you have an asthmatic patient who is really, really hyperinflated, they can kind of cause sinus arrhythmias. Some types of medications can cause sinus arrhythmias. In most cases, it's very benign and we don't need to treat it, but this is what it looks like. So again, we have a P wave, we have the QRS complex, and we have the T wave, okay? My PR interval is normal, so I know I'm in a sinus rhythm. Okay, but what's happening here is that I have different variations of time between my QRS complexes. So this one, my QRS complexes, these big guys, aren't equally spaced out along this rhythm strip, and that's why it's considered a dysrhythmia, even though it's sinus. We're not as worried about these ones. Your heart blocks are the ones that everybody gets scared of. These don't have to be scary though, because really what we're looking at is just those PR intervals. So what happens in a first degree heart block is that PR interval starts exceeding the 2 seconds, okay? We still have a QRS complex after the P wave, but it's just delayed because there's a block between that SA node and the AV node, causing a long PR interval, okay? So typically you still have a regular ventricle rate. So the ventricles, the QRS complexes are regular, and you sometimes see these first degree heart blocks after a patient that's had like MI in the past. It can be a complication of certain medications, but sometimes it's just kind of normal. Like people will have these, they're be asymptomatic, it's nothing to be concerned about. Usually treatment's not needed. Okay, so first degree heart blocks aren't something we get real wound up about, but you still need to be able to identify them. So this is what a first degree heart block looks like. So again, like I said, it looks like normal sinus rhythm, or actually usually it looks like sinus Brady, because usually because you don't have your SA node is not pacing the heart anymore. Your AV node is pacing the heart. It's usually a low rate. So a lot of times this looks like sinus Brady, but you just need to double check to make sure that the difference between the P wave, the start of the P wave, and the QRS complex is bigger than one box, which in this it is. Okay, so that you have that prolonged PR interval. Okay, so secondary heart block sometimes is a little bit more challenging. So this comes in 2 types. You have type 1, which we call a Winky Bach, or Mobitz type 1. This is recognized when those PR intervals gets progressively longer until one just doesn't pass to the ventricle. So it's not followed by, you'll have this P wave without a QRS complex after it. Mobitz type 2 is less common than type 1. This occurs with more serious problems like MIs. This is a series of non-conducting P wave, or P waves followed by a P wave that conducts to the ventricle. So you'll have a bunch of P waves that don't have a QRS after them, and then a P wave that does. So for the treatment of type 1, that's not usually needed because it usually does not impair cardiac output or cause symptoms, but type 2 usually requires medications like atropine. Okay. Type 2 is the one that might progress to third degree heart block without any warning. So sometimes we need to put in pacemakers even if the patient's asymptomatic. So this is what type 1 looks like. So you have normal PR interval, longer PR interval, longer yet, and then there's a P wave that does not have a QRS complex after it, so that's dropped. Another way I like to look at these second degree heart blocks is second degree type 1, you're going to have that irregular QRS or irregular ventricle rate or rhythm. So if you notice here, if I'm just looking at these big guys, I notice that it's not regular because I'm almost like, okay, there's 3.5. This one's about 3.5, and then this one is like, because it got dropped, I have almost 7 in between here. So quickly identifying this for me is if I see a irregular ventricle rate, I'm going to start looking or suspecting that it might be this second degree heart block type 1 or Winky Bach. So this is the type 2 where I have these normal PR intervals, but here's one that didn't conduct, normal PR interval, did not conduct, normal PR interval, did not conduct. So it's just that every once in a while I'll get these P waves that don't conduct through, but those PR intervals aren't necessarily affected. Okay, and that's type 2, and that is a bigger concern than type 1. So let me just play this video for you.
In Mobitz type 2 second degree AV block, the underlying disease is located with the His-Purkinje system. This block can occur below the AV node, within the bundle of His, or within the bundled branches. This is characterized by unpredictable failure of the His-Purkinje pathway to conduct the impulse from the atria to the ventricles. On the cardiac strip, in contrast to type 1 second-degree AV blocks, there is no change in the PR interval prior to or after the non-conducted P wave. In other words, there's no warning sign, such as a gradually changing interval you see with a type 1 second-degree AV block. In this case, QRS complexes are simply not conducted or dropped.
So third-degree heart blocks happen when the conduction system between that atria and the ventricles is completely broken. So those atria and ventricles are then pacing independently of each other. So there's no relationship between those P waves and those QRS complexes. So those PP intervals and those RR intervals kind of remain regular, but there's no correlation with one another. So for this one, you do usually give the patient medications to speed up those ventricles. And these patients a lot of times will end up getting pacemakers. So this is an example of, oops, that's not a very good example. But this is kind of an example of a third-degree heart block where you have these, your R to R intervals are going to be normal. They're regular, not like I said in type 2 where you have that irregular ventricle rate. They are going to be regular still. It's just that you see here, there's P waves that aren't associated with Q or S complexes at all. There's no association whatsoever. Okay. So when you have those impulses that aren't conducted one way and you have that conduction back, sometimes you can have things like atrial flutter happening where it's represented by that rapid depolarization of the atria. So it causes this sawtooth pattern where you have these numerous P waves that are happening. And so there's a couple P wave present for each Q or S complex. It happens in a wide variety of disorders. And we usually either treat it with medications or a cardioversion. So this is what that sawtooth pattern looks like. So you have several of these P waves followed by a Q or S complex. Okay. So atrial fibrillation happens when those atria doesn't ever really contract. So that muscle just quivers in like a really irregular pattern. It looks very chaotic. So you really don't see a true P wave at all. The ventricle rate then may be very slow and irregular because again, that's not conducting properly through that AV node, SA node to AV node. And AFib usually causes a lot of issues with cardiac output. The cardiac output can drop because that atria is never fully draining into the ventricles, and that stagnated blood in the atria can lead to thrombi. So cardioversion is usually used for treatment in most cases of AFib. So this is what AFib looks like. So you see this kind of chaos where a P wave should be. So you don't really see a true P wave. It just looks like a bunch of mess. Okay. PVCs are what occurs when you have ectopic beats originated in the ventricles. So PVCs are really common as a result of hypoxia, electrolyte imbalances, acid-base disorders. Typically, you'll see this QRS complex look very wide with no preceding P wave. Okay, so if you see frequent PVCs, this is a call for treatment of the underlying causes. You can also sometimes give lidocaine as like an antiarrhythmic to try to stop this from happening. But this is something that you would need to treat. We talked about these, and I showed you these a little bit when we were talking about suctioning. And this is kind of a dysrhythmia that a lot of times you'll see with a patient when they become kind of unstable with suctioning. So this is what they look like. So here's my normal sinus rhythm here, and then all of a sudden I get one of these wonky dudes here, which is this wide QRS complex, such as that premature ventricular contraction. VTAC is a kind of what happens when you have three or more PVCs in a row, you end up calling it VTAC. So this is easily recognized as a series of very wide QRS complexes with no preceding P wave. So the rate is usually anywhere from 100 to 150. It usually represents a very serious arrhythmia, and if it goes untreated, it can end up in VFib. Remember too, VTAC can have a pulse associated with it, or it can be considered pulseless. So the treatment includes cardioversion and medications. And this is what it looks like. So it looks like a bunch of those PVCs all in a row. And then ventricular fibrillation is a life-threatening arrhythmia because it is associated always with no pulse, because the ventricle muscle is just kind of experiencing this erratic quivering. There's no true contraction. The cardiac output then drops to zero, and your EKG is going to kind of show this very irregular fluctuation, zigzag pattern. So treatment for this would be to defibrillate. So that's shock them. Doing CPR, oxygen, and your anti-arrhythmic medications like epinephrine and amiodarone are usually indicated for these patients. So that's an example of what it would look like. Pulseless electrical activity is very rare, but again, serious because there's no pulse or there's no true contraction of the ventricles with it. So it's characterized by this ECG pattern, EKG pattern that does not generate a pulse. So it can look like normal sinus rhythm on the ECG tracing, but when you check for a pulse, there's no pulse. So this doesn't usually occur unless there's some sort of precipitating event in front of it, like tension pneumothorax. So tension pneumothorax is not going to affect the electrical impulses to the heart, but it's going to affect the heart's ability to contract. So because I have proper electrical impulses going through the heart, I'm not going to shock this patient in order to get them out of this dysrhythmia. I would need to reverse the cause, so treat the pneumothorax, or I would need to give them medications to improve the contractility of the heart. So there's one more that I did not, I think I missed one in here, and that is supraventricular tachycardia. So I thought it was on the end of this, but I'm just going to slide back here for a second. When we're talking about sinus tach, again, let me go back here. So sinus tachycardia, right? Oops, sorry. Sinus tachycardia occurs when you still have the P wave followed by the QRS complex and the T wave, right? And and it's just at a fast rate. Supraventricular tachycardia happens when the heart rate gets so fast that your P waves start getting buried inside your T waves. Okay, so typically this is what happens when your heart rate goes faster than like 140. You can end up, or upwards of 150, 180. Your heart rate is going fast enough that you don't see that P wave anymore. So see here, you see these QRS complexes. I have one bump in between there, but because my rate is so quick here that I don't have enough room to represent a P wave and a T wave, so that P wave gets buried underneath this T wave. So that's the difference between sinus tachycardia and supraventricular tachycardia. It's just that the rate is happening so quickly with supraventricular tachycardia that P wave gets completely buried, so you don't see it. All right, so that concludes the lecture for this topic. The worksheet this week is simply applying what you just learned in this lecture to a couple rhythm strips. So being able to identify those and recognize some of those basic EKG rhythm strips in the examples I provided on the worksheet. So if you have any questions, please let me know.